So welcome everybody, and thank you for joining this session during the EACTS Congress on practice TAVI procedure on TAVI simulator. My name is Andrea Arneri. I am a trained education and program manager in Medtronic, and I work for TAVI and congenital therapies. Together today with me, there's George. Hello, George.
Hello, everyone.
Is a product specialist from 3D System, a company that we're currently working on for simulating the TAVI implantation procedure. Today, we're going to run through a really simple case in order to show you all the steps that are needed to implant an evolute prosthesis into a patient. So we're going to start now. If you have any question during the session, feel free to write your question in the chat, and it's going to be answered by one of us. So you see here, we have two patients on screen, patient 1 and patient 2. As you see, we are going to base our sizing on the perimeter of the patient. You see that both patient and 80.1 millimeter perimeter. So you can see the sizing metrics below telling you that this patient is more for a 29 millimeter prosthesis. And as you see, we have some limits. We need sinus valsalva bigger than 29 millimeters. And if you see the dimension of the sinus valsalva patient 1 and 2, we have to choose patient 1 because the sinus valsalva are bigger than 29. Including the height, which is 17, so bigger than 15. So we will go for patient 1. Okay, so we're gonna start the simulation with a pigtail catheter in the non-coronary cusp. And as you see here, we can see on the bottom left the ECG, and the pressure of the patient. We have some pressure numbers on the right of the screen, and you see we have the pigtail already now in the non-coronary cusp. So the first thing we're gonna do right now is just checking the implant projections. So the implant projections are calculated from the CT scan. And for this procedure, it's important to keep in mind two different implant projections, which are the cusp overlap view and the traditional three-cusp view. I'm going to talk over these two projections in a minute. So maybe George, if you can put the 3 dots on the cusp just to understand better. So you see we have 3 dots now. The 3 dots are overlapping with the nadir of each cusp. We have the yellow one, which is non-coronary, the green one, which is right cusp, and the red one, which is left cusp. As you see, the pigtail now is in the non-coronary cusp. And just to show you a bit better, which are the projections I'm talking of, it's the first one, it's a cusp overlap view. And in this case, is RAO 24 caudal 40. So we can go in that projection. And it's called cusp overlap view because we are overlapping 2 cusps one onto the other. As you see, we are overlapping the green dot with the red dot. So we are overlapping the right and the left cusp. This is a more recent view that we are using because compared to the old one, this is helping us to really see the real implant depth of our prosthesis, and also has other advantages like better seeing the length of the ventricle, not having the spine over the screen and so on. So the first projection is the one that we're going to use to implant our prosthesis. Maybe we can do a contrast injection here. Okay, so we see that the pigtail is already pushed onto the nadir of the non-coronary cusp, and the other 2 are correctly overlapped. The other projection, on the contrary, is the one in which we have the 3 cusps aligned and at the same distance one to the other. That's called 3-cusp view. So we can go in that projection. Okay. Okay. It's not perfect. You see that the green and yellow are a bit closer compared to the red one, but in any case, this is more to show you the difference. Is a 3-cusp view, and we see the 3 cusps, the right, and the left when we do a contrast injection. Okay, so now we are going back to the cusp overlap view. That's our starting implant projection. We're gonna see what this three-cusp view will be used for afterwards. And now what we have to do, of course, it's crossing our aortic valve. So for that, we have to choose an AL1 catheter, Amplatz left 1 catheter. It's a 6-branch catheter. And of course, we have a J-tip. We need a J-tip wire, 0.35 to move the catheter into the body of the patient in order to be less traumatic for the vessels. So now George is going to push the J wire into the patient. You see the J wire going over the descending aorta, then aortic arch, and finally the descending aorta. It's not traumatic for the vessels at all. And over this wire, we're going to move our AL1 catheter that, because of the shape of the tip, will be used to cross our aortic valve. I suggest to do the crossing in this projection because here you have to basically point your AL1 tip toward the center between the yellow and the green-red dots. But to do that, you need a straight tip wire because this is aortic stenosis, so the hole is really small and you need a straight tip wire to go into that hole. So we're going to remove now the J wire, which is a J tip, so it's not possible to use that to cross the valve. And we're going to insert now a straight tip guide wire. So you see the straight tip guide wire now in the descending aorta into the AL1 catheter. We're now crossing the aortic arch with that. And now the J tip, the straight tip wire is exiting from the AL1. Now the game is basically rotate the AL1 while pushing and pulling over the straight wire in order basically to find the right spot to go into the ventricle. So now you see that George is pushing the straight tip wire and try to go into the ventricle. If it's not working, he's pulling the straight tip wire back, rotate the L1, then pushing again. It can be a really long procedure at this time if the aortic stenosis is really severe and the hole is really small. So you will need some patience. Okay, now we're keep trying to go into the ventricle. Okay, you see now we are into the ventricle. So George succeed to do that. We have the straight tip wire into the ventricle. We have the L1 right above the aortic valve. What we're doing now is going a bit more into the ventricle with the AL1, okay? And we're pulling back the straight tip wire. We're not pushing much the straight tip wire into the ventricle because it's straight. The ventricle can be really hypertrophic and there's a risk of perforating that. So at this point, we have the AL1 catheter into the ventricle, and we have to exchange that catheter with a pigtail. So we take an exchange J-tip wire. We're pushing that into the AL1 catheter. And once the J-tip will go out from the AL1 catheter, we're going to remove that and just keep the wire in the ventricle. Okay, here is really important to make sure not to lose the ventricle, so pushing on the wire. Okay, it's really important here because while you're pulling back the L1, there's a risk that also the wire comes out. At this point, as I mentioned before, we need to exchange for our pigtail. So now we're gonna select a pigtail. Okay. Why we're using the pigtail now? First of all, because we want to measure the pressure both in the ventricle and outside the ventricle to see the gradient and to see how much is the air index for aortic regurgitation. but also because of the shape of the pigtail. That's the best to check if we're not stuck in the mitral valve, and also that's the best tip shape to insert that the pre-shaped guide wire into the ventricle. We are removing now the J wire. You see now the pressure below. We have a gradient which is around 60. It's 190 compared to 136. So it's like around 55. So for sure, this is a severe aortic stenosis. Maybe George, at this point, you can see that you can rotate the pigtail. And if the pigtail is freely rotating in the ventricle, that means that we're not stuck in the mitral valve, which is a really good sign before insertion of the pre-shaped guide wire. So now we want the pre-shaped guide wire in the ventricle. We're going to choose a Confida pre-shaped guide wire in this case. And we will insert the pre-shaped guide wire through the pigtail that we have now in the ventricle. So because of the shape now of the tip of the pigtail, the wire will go out freely. Also, for this new cusp overlap technique, a Landerquist wire is suggested because it's more supportive and helps a lot with this new technique. So either Confida or Landerquist C-curve guide wire are suggested. So now we see nicely the pre-shaped tip of the wire into the ventricle, and we are now removing the pigtail. Okay, so for this patient, we are not going to do any pre-dilatation because you see we don't see any high degree of calcification, so that's not needed, and it's not even mandatory for the implantation of an evolute. And we're going now to insert our device into the patient. So we're going to select, as we mentioned, an Evolute Pro 29 millimeter. Okay. It's important, we cannot see it from this simulator, but it's important to insert our device with the flash port that you have on the handle of the delivery system at 3 o'clock. That will help a lot to reduce the risk of commissural misalignment. So we're going to insert now our device, and we're going to stop right before the crossing of the aortic arch. Okay, when you are here at this point, we can stop, George. And before crossing the arch, it's important to go in LAO projection. Okay, in LAO projection, what you want to see is that head marker that maybe, George, you can point with your arrow. We want to see the head marker there, that the thicker part of our radiopaque marker toward the right of the screen, so toward the outer curvature of the aortic arch. If you add that, that will increase the chances of commissural alignment. So we are in good position because we have inserted our device at 3 o'clock, and we're going to now push the delivery system through the aortic arch. While you're doing so, it's important to pull back a bit the wire because you want to go away from the outer curvature of your aortic arch and avoid to scratch with your device over that part, which is usually calcified. So now we're pushing on the delivery system while pulling back a bit the wire. You see that we have nicely crossed the aortic arch. Okay, we stop here and we go back to our cusp overlap view, which was a right 24, caudal 40. Okay, and our starting point is going to be with the radiopaque marker at mid pigtail, so half of the pigtail. Okay, we stop here. So we see that we have our radiopaque marker at mid pigtail. We can do a contrast injection just to check if the pigtail is still in place before starting with our implantation. And I think we can start. So now you see we are starting above the annulus, not into the ventricle, that reduced the scratch of the nose cone of the capsule over the conduction system. That this technique really reduces the risk of pacemaker implantation. And we can start now really slow to release our valve. So we start rotating the handle of our delivery system really slow. And before starting that, George, what we have to keep in mind is that when we reach the third node with our radiopaque marker, we have to stop. Maybe, George, you can stop the image and show which is the third node. So if you start from below, okay, we have node 1, node 2, and the white arrow now is pointing to the third node. When we reach the radiopaque with the radiopaque marker and the third node, at that point we have to start a sort of controlled rapid pacing in order to avoid any unwanted movement of the valve over the implantation during the implantation, and be sure to reach really nice implant depth of 3 millimeter. Our goal is to have 3 millimeter implant depth, and to have 3 millimeter implant depth, we need to make sure that the bottom part of our pigtail is between node 0 and node 1, because that the distance is 6 millimeter. So if we have that at half, we're at 3, and that's perfect implant depth to avoid conduction disturbances and to have the highest oversizing of our valve and reduce the PVL risk. Okay, we can start now. So really slow, we're opening the valve. We are, of course, a bit out from our valve, but our system will naturally go a bit into the ventricle by itself. So you don't really need to push that. It's going to naturally move forward a bit more in the ventricle. So we can stop now. We are at 3 millimeter implant depth. Sorry, we are at the third node with the radiopaque marker. We're going to do a quick contrast check to see if the valve is at the right implant depth. Maybe we can stop, George, here with some contrast. And if we start from the bottom, you see we have node 0. You can point that with the arrow. And we have node 1, which is a bit in a higher position, a bit higher. And you see that our bottom pigtail, the bottom of our pigtail is between node 0 and node 1. So we are 3 millimeter. So we like the position. And we can go on with our release. What we do now, as I mentioned before, we have to start our pacing. So we're gonna go for 160 maybe. Not really a really high pacing, it's more controlled high pacing. At this point, you see the pressure goes a bit down, the valve is more stable, and we can release the valve quicker at this point. So we start rotating the knob a bit quicker. And we have to stop when the radiopaque marker is going to reach the other radiopaque marker, which is our pedal attachment. So we stop here. You see now, and also we stop the pacing. Okay, you see now we have reached with our radiopaque marker the other pedal attachment marker. So we are 80% release. The valve now is not released yet, so you can still recapture it, but it's working. So it's no problem for the patient. Is not blocking the blood flow. And now we can check if we like the position and if we want to release our valve. So as I mentioned before, we want 3 millimeter implant depth. So we can zoom a bit to see if we are really at 3 millimeter. Okay, we can stop the image with some contrast. So as you see, we are a bit more than 3 millimeter, because if we start from the bottom, which is 0, and then you go up when 2 diamonds are connecting one to the other, that's 6 millimeter. And so now we are at 6 millimeter implant depth. According to our IFU, if it is more than 5 or less than 1, we have to recapture and reposition our valve in a higher position. So now, also for the sake of the training, we're going to show how to recapture and start over again. So we can recapture now. We don't really need to do any pacing now. We just have to resheath the valve. So it's really simple. We're closing fully the valve. Okay, and we're gonna start over. So maybe nice now to start a bit higher in order to have the valve then in a higher position at 80%. Okay. And we are going to restart now. You see that head marker, the radiopaque marker is a bit in a higher position compared to mid pigtail. We're going to start now to release the valve again. Again, we are reaching the third node. Okay, we can stop now. Maybe we can, sorry, George, to show another tip. If we want the valve a bit higher, what we can do is pushing on the guide wire, which is in the ventricle. By pushing on the guide wire, the valve will go a bit higher, in a high position. If you pull back with the wire, the valve will go a bit more down in the ventricle. We can do a small contrast injection here to see our implant depth. So we see that now we are a bit higher, in a higher position. It's a bit less than 3 millimeters, probably 1 or 2. So now we can start again with the pacing, because we are at the third node. So we're doing now the pacing, and we can start over in releasing our valve till 80% implant depth. Okay, we stop here now. We stop also the pacing. What I will do now is zooming a bit more. We can also maybe go a bit less RAO to remove some parallax. Okay, perfect. And we can do a contrast injection now. So now we're a bit higher. We're probably at 4 millimeter. So we like this position a bit better than before. We could have been a bit higher, but for the sake of time, we're not going to recapture again. We can do our final release. So which are the steps now? In this projection, we just see the implant depth below the non-coronary cusp. Okay, we cannot say anything about the implant depth below the left cusp, which is also another important implant depth that we need to understand. So how we assess the implant depth below the left cusp, we go first in the traditional projection, so the 3-cusp view. Okay, and at this point, maybe we can put the 3 dots just to show if we're really in the 3. Okay, you see we are in the traditional one, the 3 dots are aligned. If at this point we don't have any parallax, meaning that the bottom part of the valve is overlapping nicely, like you see now, we don't have to do anything else. If you have still some parallax at this point, you just need to add some LAO till you don't have any more parallax. But in this case, it's okay already. So what we do here, we have to check how much is the implant depth below the left coronary cusp. So we do another contrast injection, and we need to assess if our valve is below the nadir of the left cusp. And also here we assess if the coronaries are perfused correctly. So everything is okay. And we are going to do our final release in this projection. Why we do the final release in this projection is because we can see our aortic arch. And because we have to push slightly on our delivery system at this point, this is the best view to see how much we're pushing on our delivery system, because we see the curvature of the delivery system around the aortic arch. Another important thing to do upon release is pulling back the wire. We don't want the wire really to be pushed toward the apex of the ventricle. The wire is not helping you anymore at this time. So we can pull back the wire slightly. And also we can push a bit on the delivery system. So push the delivery system, pull back the wire. And at this point, you really have to release our valve really, really slowly by rotating the knob. So George, you can start releasing the valve. This should take 30 seconds roughly. The slower you are, the better it is in terms of stability of the valve upon the final release. So really slow release. Always remember to slightly push on the delivery system while you're doing so. You see now that the wire, it's almost into the nose cone of the valve, so that's a perfect position. In the meantime, you're seeing that George is releasing the valve. It's almost released now. We're gonna see now the pedal. They're gonna be fully out from the capsule. No need to rush at this point at all. And as you see now, we have fully released our valve. We nicely see the two pedals on top of our outflow crown. And at this point, we have to remove the delivery system from the ventricle. So it's important at this point to have the nose cone into the prey-shaped tip of the wire in order to have the nose cone centered. You see that now the nose cone is centered compared to the inflow. Okay, in this position, we have to pull back our delivery system out from the ventricle. You see that we are not getting stuck with the struts of the valve because we are nicely centered. So here is pull back the delivery system while pushing the wire into the ventricle. And we have to place now our capsule and nose cone in the descending part of the aorta in order to recapture the nose cone over the capsule of the valve. We want to do that in a straight vessel, and the descending aorta is perfect for that.
Yep, sorry.
Okay, that was okay. It was quicker, but usually here in this part, you push the nose cone, you pull the nose cone back toward the capsule of the valve, and finally. Okay, you're showing that again.
Yes.
We're closing now, okay, our delivery system, and we're putting that out from the patient. What we want to do now is removing the pigtail from below the valve, the one in the non-coronary cusp. We have to place a J wire into the pigtail in order to be as safe as possible. You see now the J wire reaching the tip of the pigtail. Once we have the tip of the wire out from the pigtail, we can pull back the pigtail safely. And then we can pull back also the J wire. We can keep it there, George, to do the contrast injection.
Sure, let me remove the wire.
Okay. Now we pull back the wire as well. Okay, perfect. We can keep the pigtail there. And also now we're gonna place a pigtail into the ventricle in order to remove the pre-shaped wire. It's always better to remove the pre-shaped wire from the ventricle because that will keep a leaflet of the new valve open, and that will show you a bit more PVL or regurgitation compared to the real situation. So it's better to exchange for a pigtail, which is softer, and reduce that risk. And also having a pigtail in the ventricle will allow you to measure the pressures. So you want to see if the gradient, of course, is decreased now that you have implanting a TAVI inside. So we're moving now the pre-shaped guide wire. Okay, you see now the pressures, 135, so the peak gradient is basically 0. And we can do now a contrast injection. So we move now the pigtail that you have in the ascending aorta in the 1/3 top of the valve, so in the outflow crown. Okay, that's perfect. Remember, this is a supraannular valve, so this is why we want to keep the pigtail so high. And we're going to do now a contrast injection. Okay, the contrast injection is showing that there's a really trace PVL below the left coronary cusp. That's a bit not too much, in my opinion. We can go now in cusp overlap view and do a final contrast injection there because we want to really assess the implant depth of our valve in the cusp overlap view, which is telling you the true implant depth. We can maybe also zoom a bit now. Okay, can we remove some? Okay, Can we remove some RAO? We want really nice parallax now. Okay, perfect. And now we do a contrast injection. And you see that our implant depth is a bit higher to what we wanted to achieve. 3 millimeters is probably 5 now, but still it's there's no ECG problem here, and we don't have much PVL, so we can accept the result. If you really want to be to reach a perfect result, you could do a pulse dilatation here, but that PVL is really traced and is gonna disappear over time because the nitinol is gonna keep pushing over the aortic annulus. At this point, what we have to do is really only remove the pigtail from the ventricle. The best is to insert a J-tip wire into the ventricle if you want to be super safe. We insert now, you see the J-tip wire into the left ventricle. It's always better every time we move our catheters to do that over a wire. And now we are pulling back first the pigtail and afterwards the J-tip wire. Okay, and now we also pull back the J-tip wire. And basically this is it for the procedure. Some physicians would like to do also contrast injection now without anything into the ventricle, without the pigtail pushing over the leaflets. But if you want to save contrast, that's not really needed. At this point, you simply remove also the pigtail from the ascending aorta, and then it's only about closing your patient, the hole you have in your artery, the femoral point, etc. So this is it for this session on practice TAVI procedure on this TAVI simulator. Hope you enjoyed the session, and thank you very much for joining us today. Thank you, George, for your support as well.
Thank you, Andrea.
Bye, everybody.